My name's Mary Ryan and I'm the Program Lead for Team Effectiveness at the Clinical Excellence Commission. So basically I mostly work with point of care teams, helping them work around, I suppose, teamwork and communication to achieve a culture of safety. And I'm co-presenting today with my colleague Brad. I'll let Brad introduce himself.
Hi everyone, my name is Brad Lloyd. I'm the Program Coordinator for Person-Centered Care in the Capability and Culture team here at the CEC.
So, well, good. I'm just going to turn my camera off actually, just to help reduce any distractions. And hopefully you can see my slides there. Well, I'd like to start first, well, we'd like to acknowledge the traditional custodians of the lands from which this webinar is recorded today. I'm personally on the lands of the Gadigal people of the Eora Nation. I'm in the eastern suburbs of Sydney, and I know that Brad, I think, is on the lands of the Camaragal people on the other side of Sydney. And we'd also like to acknowledge the traditional custodians of the various lands on which you all work today, and welcome Aboriginal and Torres Strait Islander people who might be participating in this webinar. And we pay our respects to the elders past, present and emerging, and celebrate the diversity of Aboriginal peoples and their ongoing cultures and their connections to the lands and waters of this beautiful state that we're in. So the CEC, I guess our tagline is that we're specialists in safety and partners in improvement, and that is that we're committed to working in partnership with those that access our healthcare to ensure a positive safety culture. This webinar today is the last in a series of webinars which have been held this week to support Patient Safety Awareness Week. Patient Safety Awareness Week is an initiative of the Institute for Healthcare Improvement. And the other webinars that have happened this week will, if they're not already, they'll soon be up on our CEC YouTube channel so that you can access them in due course. So today, as I mentioned at the beginning, this session's going to be co-presented by myself and Brad, and I'm going to start off with an introduction to the current safety fundamentals for teams and give a bit of evidence and background to where they came from. We'll have a look at the safety fundamentals at a glance and look at how the safety fundamentals kind of were adapted and what additions came as a result of the 2020 pandemic. And Brad's going to take over and introduce the safety fundamentals for person-centered communication. And he'll also, before we finish today, he's going to show you where to navigate onto the CEC website to access all of our resources. So let's start with some of the key features of the safety fundamentals, and this really applies to all of the fundamentals, is that there are activities which strengthen and promote behaviours between team members and within the team environment. So there's a few key aspects to them. They are behaviour focused, so that is they can change behaviour of staff and how they or we interact with the team and with our patients, families and carers. And they're important. They're valued when staff recognise the activity, will improve their experience of work and will have a meaningful impact. They are evidence-based, and that's either through research or through safety and quality improvement measurement, and they're measurable and sustainable. So they're specific enough to determine whether or not the process or behaviours occur reliably. And they're achievable without substantial renovations. So you don't have to kind of knock down walls to use them. You don't need to go to great capital expenditures or purchase new equipment or technology. And so it's important to note too that they can't just be done overnight, or not all of them. So using preferred change models, each of the safety fundamentals can be adapted to suit the unique needs of the clinical field, as long as the key principles of each safety fundamental are observed. And we're going to talk about that a little bit later too, about recognising that no two unit or no two teams are the same. So most of the fundamentals are practical. Some require a short implementation time. So for example, testing for safety huddles could be started next week, whereas something like leadership walkarounds will require more planning and education. So at the CEC, we're focused on developing practical, comprehensive tools that enhance person-centered care and also enhance that culture of safety and move teams towards high reliability. And high reliability is something that's really kind of crept in to the healthcare language. And I'm going to talk a little bit, just touch on that briefly as we go through today. So we now have 3 categories of safety fundamentals. And the first that we're going to look at are the safety fundamentals for teams. And these were really the concept, or the label of the safety fundamentals for teams was defined by the CEC a few years ago. And this was following a review of the literature, and we did wide consultation and went to understand the experiences of working with the clinical field and in the clinical field. So a lot of us at the CEC have clinical backgrounds, and we have experience of working at that point of patient care. So over the years, we've continued to refine the safety fundamentals in line with feedback to the CEC. Either it was, I don't get this, or there's not enough resources to support this, or it's no longer relevant to the clinical field. And we've also, you know, continued to learn from the emerging evidence. And need to recognise too that most of the fundamentals and a lot of our learning came from what we found out from you. So most of the fundamentals were or are in use across New South Wales Health, local health districts and specialty networks, but with varying reports of effectiveness. So this slide lists the safety fundamentals for teams, and we'll give more detail in a little while. But as I've mentioned, they've been revised a couple of times, and we'll continue to work with clinicians to maintain the currency of the fundamentals and adapt them as evidence updates and in response to the demands of the clinical field. And I want to note too that we've applied names to the safety fundamentals, and that's just for consistency's sake. So from the CEC, we'll refer to safety fundamentals, leadership walkarounds, and we'll always be referring to whatever's listed under the resources that we've named. But if that name doesn't resonate to you or to your team or service, then feel free to change it. It's, you know, for example, not everyone uses safety huddles, or they might apply safety huddles, a different definition to safety huddles. Others use safety briefs. They might participate in network rounds or have a different name to call, you know, leadership walkarounds, for example. It's just as long as the key aspects are observed. So the tree image here represents the safety fundamentals as a solid root base or a foundation. And when they're implemented effectively, which I've mentioned already through, say, quality improvement science methodology and using plan, do, study, act cycles, for example, they'll nourish, enhance, and create growth in the key attributes of high reliability teams. So it's coming up again, this term high reliability, and that is around safety culture, you know, good teamwork, teams who use teamwork science, person-centered care, good staff experience, psychological safety, leadership and trust. And we're going to unpack that a bit more. So these weren't, as I mentioned, these weren't just ideas that we kind of plucked from the air. Apart from the hands-on experience and learning from people who are working in the facilities and hospitals and LHDs, well, where else do we go to learn about best practice? So we took a really broad and comprehensive view of the evidence to inform the fundamentals. And as I've mentioned, this evidence was combined with experiences, hands-on experience. But we'll just briefly unpack this slide. So the work on clinical microsystems, again, this is another term that's kind of crept into the health lexicon. And it's from learning from other industries, and this arises from systems theory thinking. And essentially, clinical microsystems are found at the point of care. So that is where hands-on patient care is delivered within a context. So they're made up of clinicians and non-clinicians, patients, their families and carers. And the people who make up the clinical microsystems, they're usually a team of people who come together on a regular basis and work towards a common goal. And these teams or microsystems are part of a larger organisation. So examples include any inpatient ward, an emergency department, an outpatient clinic, a community setting, and I'm sure there's, you know, many, many more that you could name. And all of the microsystems are connected with some having more natural associations than others, so that you might consider delivery suite and postnatal units, for example. And so a shift in one microsystem will impact others, and this will impact patient care delivery. So this can be seen in transfer of care, when transfer of patient care is done well and when there are gaps in it, and how that can shift. It can shift the experience across a number of other units. And human factors principles underpins patient safety, and it's through a better understanding of the behaviour of individuals and our interactions with each other and with the environment. So human factors offers ways, or has helped us to understand ways to minimise and mitigate for that human fallibility. And there's no doubt that safety is dependent on teams, and it's not enough to put a group of people with the right skills together. And there's a very often used quote that you can put together a team of experts, but this will not necessarily make an expert team, because these people need to know how to teamwork. They need to know when, where, and how to share their skills and knowledge. And healthcare is complex and dynamic, and it's not possible for a patient to receive safe quality care from one healthcare professional or one professional group. So therefore, working in a siloed or tribal way just can't protect for safe care. And often referred to as the way we go about our work, relevant to risk, a positive safety culture is reflected in better outcomes for patients and for staff. And it's through our understanding of clinical microsystems, as I mentioned earlier, that the culture in one unit, getting a lot of feedback, the culture in one unit contributes to and informs the culture of an entire organisation, and vice versa. So safety culture and the quality of interprofessional teamwork is directly correlated with clinician emotional exhaustion and ability to engage. And this really, like we've known this, and we might not have put this at the forefront for a long time until I'd say 2020, it just got thrust forward that, caring for the caregivers, because in turn, this is going to impact on the care of our patients, or the experience of care for our patients. And there's a rule called the NEMO-DAT rule, and this states that you cannot give what you do not have. If you don't have a house, you can't give it away. You don't own it. If staff do not feel cared for, or aren't able to practice their own self-compassion, and when I say care for, practice their own self-care, that could be as little or as much as taking breaks, scheduled breaks. They're less likely to be able to provide compassionate care. But that's a talk for another day. And the evidence is strong on the use of mindfulness for increased awareness and focus. And mindfulness practices can be formal or informal. They simply train the mind to be present in whatever activity we're engaged in. So informal ways of bringing ourselves to the present could be as simple as when we're washing our hands, when we're using a hand sanitizer, to really focus on that experience before we enter into a patient encounter. When we wash our hands, to really focus on that, so that we can kind of somehow leave, the patient that we've just left, and not be thinking about the patient we're down the line, but to engage ourselves in the encounter that we're about to enter into where possible. And then there are formal mindfulness practices, which is where we assign, a certain amount of time every day to engage in a more mindful meditation. So it's an interesting subject of research now that's coming through, is how attention to individual mindfulness practices, as simple as what I mentioned before, contributes to a collective mindfulness. And what I mean by collective mindfulness is that shared awareness and attention of a team to emerging events within a context. And this is really, I suppose, the subject or what makes high reliability organisations what they are. And these organisations are ones that maintain a low record of harm, where errors can have catastrophic effects. And often when we think of high reliability organisations, we're referring to airline industries and nuclear power stations, for example. But when preventable harm happens in hospital, we might not down a jumbo jet full of people, or destroy a whole community with a nuclear eruption. But when preventable harm happens to one patient, it's going to have catastrophic effects, not only the patient, their family and carer, but also for the staff involved. And that's another reason why we've really turned our lens to how these organisations work. So while the evidence here has been presented in discrete boxes, it will come as no surprise that there are overlapping themes in all of the literature, and that saturation of these themes is quickly reached. We're just going to take a bit of a closer look at high reliability. But yeah, all of those little boxes could be merged into one. So as I mentioned, about a high reliability organisation. But to be a highly reliable organisation, you need to have highly reliable teams working within the organisation. So in healthcare, we strive for high reliability because, like other industries, our teams operate under a high degree of stress in an error-prone environment, as I mentioned, where error can be catastrophic or fatal. And so through the years of research, key components of high reliability teams or organisations have been identified. And this is where healthcare's turned its lens, because it's nothing different to what we strive for and require in health. And so that they have effective leadership at an organisational and at a local level. And the leadership has a strong focus on safety culture as an ongoing process, not as an endpoint. And it's the leadership that really sets those conditions or creates the conditions for a culture of safety. And these conditions are set for openness of communication, where leaders meet with point of care staff. And hopefully these sort of things will ring bells when we go through the fundamentals in a little bit more detail. So in other words, the exec will meet with the staff where the work is done to understand where the greatest risks are and what's really working well to share learnings. And in these environments, staff feel it's okay to speak up for safety, regardless of their position, clinical or non-clinical. So they're data-driven and they view problems from multiple perspectives. They don't just focus on one aspect of work or see aspects of work as separate, but instead they know how the parts all fit together. And high reliability teams see the data as a trusted source and an opportunity to reflect. And this includes collecting and probing data on near misses. And this was the subject, really, this was discussed really well in the M&M webinar this week. And as I mentioned, that'll be up on the CEC YouTube channel soon. And as I mentioned previously, they set the conditions for mindful working. So that is that collective mindfulness that I mentioned. And it was first described as a concept relative to high reliability. So collective mindfulness can be achieved through the judicious use of safety huddles, for example, and post-incident huddles. It's how we gain our situational awareness as a team. So this model, you might be familiar with this model. It's an adaptation of a cultural maturity model, which has been around for probably 40 odd years now. It's used in lots of industries and it's been adapted for health. This one was an adaptation by Frankel and Leonard, who have done a lot of work in teamwork and human factors and high reliability. And I think, we can be really proud in New South Wales because we're known as one of the best healthcare systems in the world. And we continue to move forward towards that generative or highly reliable state, but it's hard. So we've moved on from that, that red box in the unmindful culture, and that's where individuals really work in a siloed way probably more towards the individual goals rather than team goals. They might not pay attention to processes or collaborative ways of working. But to be proactive requires teams who work together collaboratively and have standardised practices where the unpredictable becomes predictable. And this means that healthcare workers organise their work so that they can recognise when something's going wrong before it's actually gone wrong. So having said that about standardisation, high reliability recognises that over-standardising can increase risks and therefore embraces the variations that affect patient safety, such as the way individuals or teams interact with one another within a particular context, and the fact that each patient is different as well. So there is recognition that each clinical unit has its own unique needs, dependent on the patient cohort and the geographical setting. So, for example, a metropolitan emergency department will have different needs to a rural emergency department. So there will be standardised processes, but there needs to be a way that these can be adapted and flexible to fit the unique environment. So hopefully the safety fundamentals, the idea is that they will help teams to achieve this by, you know, recognising the key aspects which can be tailored to a given context. So just at a glance, safety huddles. They've gained a lot of traction across New South Wales, but with varying degrees of success. I still hear occasionally a few groans come out, but they're really just so essential. And you'll know, you know, from what we've learned last year, how much people relied on huddles or some form of safety huddle to get communication across, particularly when things were changing on a minute-by-minute basis. So they're meant to be brief, like any change. Safety huddles succeed once they've had some planning and are constantly adapted. If they don't work well one day, they need to be adapted to suit the team. They're not meant to be a second clinical handover or a time to talk about what has. Rather, it's a time to talk about what is and what could be. And so safety huddles, as I mentioned, is a way to build that collective mindfulness that the things we miss when our focus is somewhere else. So leadership walkarounds, there's enough evidence out there to support the effect of leadership walkarounds when they're done well, and they're an opportunity for management or at an executive level or a senior level to hear from the perspectives of staff that things are going well and the issues of concern which relate to patient and staff safety. And they bring added benefit because they immediately resolve concerns or shared learnings. And they're meant to be delivered in a positive light and not one where staff feel like they're being checked up on. And of course, there needs to be a feedback loop which details follow-up action. So there's a couple of, quite a few districts and networks in New South Wales who have adopted leadership walkarounds or whatever. They're all called something different. And these were a couple of quotes were involved in the evaluation with one network, a couple of quotes from people who found it a really positive experience when the executive took the time to come to their unit, no matter where they were, you know, out in the back of far western New South Wales, for example, and felt that they got to see the exec as humans, and the exec, you know, they could put faces to names, for example, and they felt kind of validated for the care that they provided. Quality learning boards, and I'd like to acknowledge Western New South Wales LHD for allowing us to use a copy of their prototype. So Western New South Wales developed this prototype based on their safety and quality plan, and they tested it in different facilities out there in, you know, small multi-purpose service and a district hospital or a larger hospitals. But they're really, you know, an indicator of internal as well as external transparency, and they're learning boards, whatever you call them, are a driver for reliability and harm reduction. And transparency is an essential tool in a culture of safety. So these boards don't contain static information, but are updated regularly, and they're placed in public places. And bearing that in mind, and if it's at all possible, and, you know, in our era of social distancing, if it's possible to do a huddle or a safety huddle in front of a board, that is the ideal, but it's not, you know, that needs to be carefully planned. So the design needs to be fairly simple and preferably fits with the unique needs of the team. So they can display outcomes of safety indicators, staff and patient experience, what you said, what we're doing, what we're working on now in terms of, you know, our greatest risks at the moment. Multidisciplinary team, this is where the team, it's like a care coordination round, where the team come together with the patient, wherever that might be, at the bedside or wherever that is, and brings together the multiple disciplines involved in the care to ensure that everybody's on the same page and to give the patient the opportunity to participate in decision-making about their care. And the last two, I think the intentional patient rounding has been used a lot and is commonly performed by nursing staff where a patient's not left for more than an hour without a review by a clinician. So it's reported to offer reassurance to patients and their families and carers when they know that a clinician is regularly reviewing them, and it has the potential to prevent harm occurring and for changes in patient status to be identified quickly. And lastly, M&Ms are a safe space for learning rather than a space where judgment, because they're a multidisciplinary team. That is an interprofessional team, so everybody involved in the care of the patient come together and are engaged in the process for system improvement using data and analytics to help inform discussions. And again, please check out the webinar. So just before I hand over to Brad, I wanted to mention what happened, last year, and in response to the demands placed on the system, we developed some additional resources which were added to the safety fundamental kind of compendium, and they remain relevant. The content for these resources was sourced from national and international experience, as well as drawing on crisis management evidence. So there's themes that included psychological safety, staff wellbeing was really big up there, leadership, person-centered care, and mindful working. And what are some of the learnings, some of the findings arising, particularly from the NHS, where they were under significant, continue to be under significant pressure, are included here. And what they found, and I think, and what, from some of the conversations I've had with teams, that safety huddles or briefs and debriefs were prioritised. People needed to know what was happening now. Proactive thinking rather than that constant reactive work. Things happen much faster. There was much more visible leadership and collaborative leadership styles, and the hierarchical structures were flattened as we reached to those people working at the point of care for advice and for their expertise to help manage what was happening. So my last slide is, how can I prioritise the fundamentals? Because like for anything to work, I think I mentioned that, you need to have staff engagement, and you need to kind of create a compelling need for the change to guide the improvement. So we've designed the team stripes to be structured and practical, to support point of care teams to really identify their patient safety improvement priorities, or to kind of escalate, like I said, show that compelling argument for change with whatever priorities are needed. And it's a way to bring in improvement science to test and implement changes. And again, like I said, it's context driven, and it recognises the unique identities of every clinical team and relies on their own local data to help drive the change. So that's it from me. I'm going to hand over to Brad now. I didn't mention earlier, but hopefully you're using the chat function to type in any questions, and we will be giving you time at the end for questions. Thanks, Brad.
Thanks, Mary. Can everyone hear me?
Can now.
Oh, excellent. Yeah, I was on mute. So thanks again, Mary. We've heard about the safety fundamentals for teams. I'll now focus on the safety fundamentals for person-centered communication. And everyone can see my slides okay?
Yep, all good, Brad.
Thanks, Mary. Okay, so first a reminder of why we need to focus on and improve person-centered communication. We know that we don't always get healthcare right, and in recent patient experience results from the Bureau for Health Information, nearly half of adult admitted patients surveyed reported that they did not feel involved in decisions about their care, and more than half said that health professionals did not discuss their worries or fears with them. And unfortunately, despite the acknowledgement of the importance of person-centered care in our health plans and strategy, these two measures have remained basically the same over the past 5 years. New South Wales health complaints data also shows us that roughly 1 in every 3 patient complaints relates to staff communication. Therefore, there is still clearly an important gap between what consumers expect and what we are doing in practice. And this means that there is opportunity to improve person-centered communication despite all the great effort that everyone is already doing in healthcare. Just earlier this year also, the Beryl Institute released their patient experience report showing that the top 2 things that Australian patients rated most important about their experience of care was that they felt listened to and that staff communicated clearly in a way they could understand. And those thoughts were echoed this morning in the plenary if anyone was listening to the Consumer Health Forum. So given this gap and its importance to healthcare safety and quality and to what patients value, our team focused on identifying existing effective and practical ways of improving communication between staff and patients. The well-known PICA principles of person-centered care, which you can see on the slide here, in particular, patient and family involvement, information and communication, and respect for patient preferences were used to guide this process and led us to identify 7 key resources, which we called the safety fundamentals for person-centered communication. We worked with a consultant and our people partners to bring these resources together. The resources are targeted at nursing, allied health and medical teams, and some are also relevant for support staff who interact with patients. The overall intent of the safety fundamentals for person-centered communication is to support healthcare teams in delivering high-quality care by improving patient involvement in decisions about their care, so about shared decision-making, and improving patient understanding of their healthcare condition and management, so around health literacy. And this should help to improve patient experience and outcomes and reduce adverse events and costs related to poor communication. For the visual learners, this slide incorporates the safety fundamentals in a concept map. So you can see the safety fundamentals are listed on the left here, including Teachback, hello, my name is, reflect to care, patient delivered handover, the conversational health literacy assessment tool or chat, reach, and what matters to you. The intended outcomes of the safety fundamentals are on the right, which I just mentioned, and overarching aims at the bottom. And many of you will likely already be familiar with some or all of the safety fundamentals and aware that they're available and are being used. Our goal really is to raise wider awareness of these and support teams to further embed them in practice. And to help achieve this, we've created information sheets for each safety fundamental, an implementation guide and supporting resources. And these are available from our website, which I'll run through at the end of the presentation. I'll now take you through each of the safety fundamentals, and there's no hierarchy in the order in which I'm going through these. And a reminder also, like the safety fundamentals for teams that Mary was just talking about, teams can choose to adopt one or more of these based on their needs. So the safety fundamentals are not a bundle that needs to be implemented all at once. So firstly, hello, my name is, and this safety fundamental is about reminding and prompting staff about the importance of introducing themselves to patients and their families and carers, despite the busyness of day-to-day work. Just this simple step alone can have a positive impact on a patient's care and experience. I think best said in the words of Dr. Kate Granger from the UK, who co-founded the Hello, My Name Is campaign. Kate was a geriatrician and cancer patient who died in 2016. And she said, during a hospital stay with post-operative sepsis, I made the stark observation that many staff looking after me did not introduce themselves before delivering my care. It felt incredibly wrong that such a basic step in communication was missing. I firmly believe it is not just about common courtesy, but it runs much deeper. Introductions are about making a human connection between one human being who is suffering and vulnerable and another human being who wishes to help. They begin therapeutic relationships and can instantly build trust in difficult circumstances. The next safety fundamental is what matters to you. This is a questioning approach that can be used to develop an awareness and understanding of important information about a person that can influence their care experience as well as outcomes. And it aims to move the conversation focus from what's the matter with you to what matters to you. And by doing so, aims to encourage and support more meaningful conversations between patients and clinicians. There is a template available from our website that staff can use as a prompt to get to know their patients beyond their presenting illness. For example, by asking patients to share their preferred name, the people they are close to, their hobbies and interests, and daily routines. Moving on to Reach now, and Reach is a system that helps patients, their families and carers raise their concerns with staff about worrying changes in a patient's condition. It aims to improve patient safety by acknowledging the important role of consumers in recognising and responding to deterioration. For those not familiar with Reach, it's an acronym that stands for Recognise, Engage, Act, Call, Help is on its way. So if a patient, family member or carer recognises deterioration in a patient's condition, the first step is for them to engage with their nurse or doctor and tell them about the concern. If they are still worried, they can then take action by asking for a clinical review. And if still worried or not satisfied with the response, they can call the emergency team by phoning the unique Reach number for that hospital. Help will then be on its way in the form of the emergency or rapid response team to review the patient. Reach forms part of the overall New South Wales Health Deteriorating Patient Safety Net System, which includes Between the Flags, which I'm sure everyone's very familiar with. I'd like to point out also here that health services are required to have a consumer-activated escalation system, such as Reach, and this is outlined in the New South Wales Health Policy for Deteriorating Patients, which was updated last year, as well as in the national standards. So there is an existing mandate for health services to implement this safety fundamental. And there's resources, including the flyer that you can see on this slide, available on our webpage to assist with implementation. Moving on to the Conversational Health Literacy Assessment Tool, which is a bit of a mouthful, or CHAT. This safety fundamental includes a series of 10 open-ended questions across 5 domains that can be used conversationally as part of the patient assessment. You can see the questions listed on this slide. For example, for domain 3, health information access and comprehension, one of the questions is, how difficult is it for you to understand information about your health? Rather than assuming that the patient has supportive or non-supportive health behaviours and knowledge, the chat questions can be used to find out this information from the patient directly to help identify health literacy support needs, as well as barriers and challenges that may be preventing patients from managing their health. This increased understanding can help healthcare teams to better meet the needs of patients. For example, if the patient responded that they find it difficult to understand information about their health or condition, that would indicate the need for staff to perhaps try different approaches to provide this information. Chat questions are not intended to be delivered as a checklist. They can be used selectively based on what information is likely to be most valuable for the patient's care and for the clinician's understanding. Okay, the next safety fundamental is the patient-delivered handover, which is really just that. So that's where the patient leads their handover about clinical management, progress towards goals, and discharge planning. And this is different to the traditional handover, where it is not uncommon for the patient to be a passive bystander, while staff talked about the patient in front of them with little patient involvement. We have a suite of resources available to help healthcare teams test the patient-delivered handover model. This includes an implementation guide, as well as a welcome and invitation letter and patient prompt sheets. And these resources were all based on the work from Kim Maddock, nurse manager from Nepean Blue Mountains Local Health District. Kim implemented the patient-delivered handover in Nepean Hospital and found several positive outcomes. These included increased engagement with patients, families and carers, reduced complaints about communication, improved patient safety and satisfaction, enhanced patient understanding about their treatment, and increased staff satisfaction and interdisciplinary collaboration. There are prompt sheets available for different clinical groups such as maternity, mental health, falls risk and medication risk. And Kim is very happy to be contacted for those interested in finding out more about their experience in the Nepean Blue Mountains Local Health District. Okay, we know that patients often cannot recall information they've been given by healthcare staff. both from research and from our own clinical experience. The Teachback safety fundamental helps to address this by providing a communication method for staff to use to explain information. And this involves breaking up important information into 1 to 2 chunks by asking patients to repeat the information in their own words. And then any missing information can be clarified or re-explained in a different way until the patient can recall the information. Researchers found that using Teachback can improve patient knowledge, recall and retention, improve patient quality of life, and contribute to reducing hospital readmissions. As well as clinical staff, support staff may also use Teachback to improve communication. For example, front of house staff providing directions to a patient on where a particular ward or clinic is located. And our information sheet for this safety fundamental includes a link to a really comprehensive education program that was developed by Deakin Uni and South East Sydney Local Health District to support staff effectively use Teachback in practice. And the final safety fundamental is reflect to care. This is a prompt for reflective practice to help staff recognise their assumptions and biases. And we all have our individual biases and assumptions. And I know I definitely did working as a physiotherapist. And it's important to try to understand and recognise these and what impact they could be having on the patient care. For example, if staff have thoughts such as the patient never does what I tell them, the patient didn't listen, or that patient is a difficult patient, these are opportunities to explore our self-beliefs. Reflect to care involves staff asking themselves questions such as, how is the patient's life or situation different to mine? How might that influence the patient's outcomes? How can I understand it better? And what could I do differently next time? So that's an overview, a quite brief overview of the safety fundamentals for person-centered communication. I just wanted to highlight also that the safety fundamentals can help healthcare organisations show evidence of meeting criteria across all of the 8 national standards. This slide, for example, shows the standards and criteria that the What Matters to You supports, and the links to standards for the other safety fundamentals. That's all included in the implementation guide. We know, as Mary said before, that providing these safety fundamental resources by themselves is unlikely to change practice. So it's really crucial that the local context is considered when deciding how to integrate the resources. And this includes identifying factors that act as enablers and barriers to change. Research has identified several enablers of person-centered care, such as strong, committed leadership, staff satisfaction and positive staff relations, staff cultural diversity, health professional values and role expectations. Barriers to person-centered care include staffing constraints and low levels of staff experience, high staff workloads and time pressures, physical resource and environment constraints, and unsupportive staff attitudes. We have provided information in the implementation guide to help healthcare teams consider these factors when planning to adopt the safety fundamentals in their setting. And our team is also available to help support this process. Okay, so I'd like to just stop there for a moment and give you a brief overview of our webpage where you'll find the safety fundamentals. So just bear with me briefly while I end this and bring up the browser. Okay, can people see the web page there?
Yep.
Yep. Okay, great. So this is our landing page. So if you're in a health service through the intranet, clicking on the Clinical Excellence Commission, this is where you'll land. Or if you're coming in via Google, just searching Clinical Excellence Commission, this is the landing page. And so the tab across here, improve quality. We're the first one underneath here, teamwork, culture, and person-centered care. And on this landing page here for our team, you'll see the safety fundamentals as a second box across here. And this has all the information that Mary and I have just been talking about. So safety fundamentals for teams, for person-centered communication, and also the resources that Mary mentioned during COVID-19. So if we have a look under teams, and then clicking on, for example, if you're interested in safety huddles and you wanted to learn more about safety huddles, there's the implementation guide, which you can download there, as well as supporting resources. So posters and information for clinicians. And under person-centered communication, so this top link here is a one-page overview of the safety fundamentals. And then there's the resources for each of the 7 safety fundamentals. So information sheets, as well as an implementation guide for the patient-delivered handover and supporting resources. And down here at the bottom is the implementation guide overarching for the safety fundamentals for person-centered communication, and that includes the links that I mentioned to the national standards. So back to, this is where our landing page again, as I said, for our website. So this has all been updated recently. So the feedback we've had is that people can find information a lot more easily now. So if you're looking for information about a particular issue that you've heard us talk about, then there's some tabs down here on the right hand side, and we're also very interested in your feedback and comments around any of the resources that we've mentioned, or also our new website. That would be great, and this box here will take you to a link to provide any feedback. But that's the end of my part, and we're also very interested in any feedback from anyone who's used the resources now, or any questions for Mary or I.
Can I just say thanks, Brad, for that. Actually, I'm getting an echo. Can you just turn your mic off?
Yes.
Just for a sec. Can I just say, in I'm really looking forward to kind of getting back out into the clinical field when things settle down a bit more after the vaccine rollout's being sorted, and teams feel able to have people down with them, to see how the fundamentals are being used, and to learn from those of you who are using the fundamentals, how could we make it easier for you to use them, and also to get some of your, some good quotes and some information, really. That's it. That's all I had to say, Brad. But thank you everyone for tuning in today and for listening to the presentation. We hope you found it helpful, but we're really open to any questions or comments, as Brad mentioned. And if there are none, we can give you back some time in your day, your Friday. The sun was out for 5 minutes, but the rain's come back.
Were there any questions in the chat, Deb?
It's Colleen Vander here from Central Coast. I've just arrived in from New Zealand, and it's really great to be able to be part of this. So thank you very much for your time today.
Great, Colleen. It's great having you. Thanks for tuning in.
Thank you. And any questions in the chat, Mary or Zeb?
Just lots of thank yous.
Okay.
Oh, all good. That's great. Thanks, everyone.